So we're going to move now into the final Q&A session, which is going to be focused on treatments. I'm going to welcome back Danny, we're going to welcome back Marianne, and we're going to welcome back Betty as well, if Betty's still there. So we'll now go to the audience's questions. Please keep asking your questions through the Q&A function, and we'll try to get to as many of these questions as we possibly can in this final session on treatment. I'm going to take Chair's prerogative to ask the first one, though, because I'm really interested, Danny, in what you said about autoimmunity and could COVID be an autoimmune disease. Am I wrong to think that what Betty presented, that the most common age group is middle-aged and the most common patients are female, that's also the age and gender of patients that also are more likely to have autoimmune disease?
Yeah,
and if that's the case, is there data showing that the sort of phenotype, the immunology is similar between autoimmune diseases and COVID?
Yeah, no, I think it's a really helpful point, isn't it? Because autoimmunity is much more common in most cases in women than in men, and that's never been entirely, perfectly pinned down. But it wouldn't take a genius to work out that's to do with hormonal differences in impacting development of the immune system. And so if you try and join up the dots between that and our discussion today, we're part of the way there, aren't we? Because lots and lots of observations on how COVID infection per se leads to new patterns of autoimmunity, including those kind of pictures I showed. And, some really impressive data, for example, showing how people who've had COVID have lots of antibodies against proteins in their skin. And, you'd love to be able to say, what does that have to do with the rashes that people see in long COVID? So the final bit of that circle hasn't been squared yet, but I think it will be soon. And I think that'll be really helpful.
Yeah. So this is a follow-up to that would be obvious for a lot of autoimmune diseases. What we do is we suppress the immune system with things like steroids. And we started using steroids in the middle of last year as a treatment for COVID. Question Danny first and then maybe Betty as well. Is there any evidence so far that as the pandemic's gone on and we've used more drugs that suppress the immune system, we've seen less long COVID or it's had any impact on long COVID?
I'd be keen to what Betty thinks. I don't think I've seen or heard of any evidence like that. And yeah, or even just that steroids, sure, but even the aggressive use of antivirals could have had some impact on long COVID. And I don't think I've seen evidence for that yet either, but I'd be keen to hear any other evidence. But I was being a bit coy talking about the toolkit and the goodies on the shelf, but there is an awful lot of stuff out there apart from just steroids if we only knew which stuff to try and put into proper trials, and that's getting closer.
So I can
add to that. So there aren't any evidence from the recovery trial investigators, as Danny quite rightly pointed out. And I think that'd be really valuable because they have a really rich resource there. But we do have some data from the FOSS-COVID consortium. So the FOSS-COVID group of investigators have put out the first paper on 1,000 patients across the UK, and they did not find an association between the use of steroid and recovery. And recovery is defined by very subjective, like how the patient feels from a symptom perspective. So that was quite interesting.
Yeah. So a lot of our patients are looking for kind of practical tips about what they can do over the next few months with their symptoms. So I'll start with you, Rania. So you showed the nice rehabilitation program that you've got. A lot of our patients will live in places where they can't access rehabilitation programs like that, or they haven't been referred. Are there things that patients could just be doing themselves that could try to at least mimic some aspects of the program you've described?
Yes, of course. We advise all patients start even, walking outside, minimal exercise with safety. Unfortunately, patients that need oxygen therapy after discharge it's not safe to start something like that. They need respiratory physician consultation, pulmonary consultation, and so it's difficult for them to exercise. But for patients that were not hospitalized and they still feel, they complain about fatigue and dyspnea on exertion, they can start exercise, let's say for about 10 to 20 minutes a day, and gradually increase time and intensity.
Yeah. And if patients do experience that sense of real exhaustion, hours after or the day after exercise, what's your advice? Should you try and exercise through the fatigue, or should you rest? That's a really common question we get.
You need to follow them up. You need a CT scan to check if the infiltrates are still there. Maybe you need a spirometry to check their lung function, and also you need cardiological evaluation, because some of them suffer from myocarditis. It was not diagnosed during the hospitalization. And also you have to be very careful with the patients that suffered from pulmonary embolism or deep vein thrombosis during hospitalization. You need to be very careful with those patients too.
Yeah, so that's coming also through in the Q&A and in the chat. Some patients saying I've been diagnosed with myocarditis, some saying I've had a pulmonary embolism, but an awful lot of patients saying, sort of as going back to Danny's analogy, they've just had the consultation with somebody who said you've had long COVID, but they've not necessarily had many tests. And so it seems to be quite inconsistent. Maybe a view from everybody on the panel on how patients can access testing, or what kind of tests people should be expecting. Maybe start with... Yeah, go, Rania.
We follow patients to the outpatient clinic, and we actually have a protocol. We see them within a month after discharge, and all of them have blood tests, a CT scan within the 4 to 6 months, a spirometry if they still feel dyspnea, and also they have blood tests and an echocardiogram. And actually we detect problems. Yeah, patients that still have symptoms, they end up with problems.
And maybe Betty, do you want to expand on that in terms of testing?
Yeah, thanks, James. So, I mean, I think this is quite a complex question, because in some ways it really comes down to a balance between benefits to patients from doing the investigation and the costs of the investigation. So if I were given, an unlimited well of money, sure, I'd do all my fancy investigations. But I think from a primary healthcare perspective, I'd hope that there's at least sort of some basic screening test that gets done to exclude the more major complications. So, for instance, cognitive assessment, ECG, 12-lead ECG, and someone who's complaining of palpitations or chest pain, some basics or even blood tests to look for troponin and BNP, some basic investigations at the GP level. And should any of them be abnormal, then you're quite sure that this is actionable and it needs to be referred on to a specialty service. Now, if I had all the money in the world, I'd do my multi-organ scan on everyone and look for, look to see if there's something that could explain it, because, I'd like some answers. I need some tangible, outcomes. I need to see what's going on. And so, yeah, that's really how I'd manage it if it was up to me entirely, and if I had all the money in the world. But neither is the case right now. So.
Yeah, I mean, I think it is an important point. Danny's slide about, we're potentially making 10 to 20,000 long COVID patients a day in the UK. We don't have enough scanners to scan that many patients. We cannot scan 10,000 patients a day, so we do need investigations that are practical. Another set of questions that's coming through a lot is around the brain fog and how to cope with that. I think that's difficult, obviously, because we don't have trials. But Marianne, you mentioned that that's something that you've experienced. How have you coped with and managed that as a symptom?
Well, I still have it, so and now I'm completely exhausted, so I will rest the next couple of days. But so what I do is, what I find is easier for me is when I started doing breathing exercises, and then I take cold showers. That has lifted my mood. That has lifted my clearance. I get still quickly exhausted, but still that is what I try to do. Even if I do, I did some push-ups for a period just before I went to bed. I did some breathing exercise and I could do push-ups. Before I got ill, I did 40 push-ups and like around 6 to 7 chin-ups, so I was fairly strong. Now I try to do for 5, and then before I did the breathing exercise, first I did the breathing exercise, and then I could do this without anything. But then for me, this illness goes up and down, so I cannot give a clear answer on the brain fog. But I still try to do some brain tasks to keep the brain active. But yeah.
Yeah, and I'm curious, Rania, whether you've seen with some of your patients that your program is helping with the neurological symptoms as well as the physical limitation.
Actually, to that program, patients didn't refer any neurological signs. Most of them complained of fatigue and dyspnea on exertion, and they had problems, to concentrate and to be able to work, actually. So the exercise and the breathing exercises help them, and also the psychological support help them to just overcome this post-traumatic stress.
Yeah. So a lot of the problems that we're having in answering the questions about what to do is we just don't have enough data. So, and it's very difficult for doctors to make a really firm recommendation when we don't know what causes something. Or Danny, because I know you've written about this in various forms, how do we as clinicians cope with uncertainty? So when we don't know the answer, and there's a lot of anecdotal evidence around, how do we help people? Because we really want to help people, but we don't always know the right answer.
Yeah, no, really, really important question. So, the first thing to say is that things in time of COVID have moved forward really, really fast, and there's a real will to foreshorten all of these debates, and do things that used to be done in 6 years and get them done in 6 months. And the secret is just all of the obvious, isn't it? It still puts pressure, I'm afraid, on the patient groups, because they've really led the way. So they have to continue to be demanding and to press the point and press the demands and press the referrals. And then the doctor needs to listen, and we need to design the right trials to actually investigate our hypotheses and get the answers they need. It's all of the obvious, but just done at warp speed.
Yeah. And also being brave enough to say when we don't know.
Yeah.
Betty, anything to add to that?
No, I think everyone's essentially read my mind. These are all very important discussion points that will continue to evolve over time.
Yeah, so we've only got a couple of minutes left before the end. And so I want to go round and just give everybody a chance to give their kind of top tip, or, what I would do over the next few months, either advice to the patients that are listening, or we've got a lot of healthcare professionals, what should we be focusing on? What should we be researching? So I'll go in the order that you appear on my screen. So starting with Rania, what do you want people to really take away today?
We don't have still all the answers, but we will be soon. And I hope we will overcome this pandemic and its consequences. And as a clinician, I encourage my patients, to stay calm and to be productive and to start be active and, live their life. They should feel, lucky that they survived all this. So they should do their best to come back to their life and their families.
Okay. And Marianne, anything else you'd like to say to your fellow patients or to the clinicians that are listening?
I would just say for the long haulers like me that the breathing techniques, I think, and the cold shower is good, and still try to do something good for your brain. I do meditate. But I'm starting to be a little bit sort of impatient for this because here in Denmark they say that you should rest, and I'm tired of resting, to be honest. So the breathing techniques and the cold showers.
Great, thank you. Danny?
Yeah, no, all I'd add is I'd like people to try and keep up their optimism, because I do think that there are answers on the way. Honestly, I think all the right things are being done. And I think there will be diagnostics soon, and there will be therapeutics soon. And all you can do in the meantime, I think, is to continue to be a very demanding patient who really irritates your doctors and irritates your policymakers to make your demands. Because how else are you going to be heard?
That's permission from Professor Altman of Imperial College to be as irritating as you like.
Yep.
Betty, final word.
Yeah, so I mean, I was going to say exactly that. I think we've learned a lot from this session, just as much as the patients have, and and physicians managing them. And I really think that such forums where we're able to interact with each other and share our concerns, and be honest about what we don't know, and where we need to channel our funds and our energies and minds to answering. So I think this was a really, really exceptional session for me, and it's definitely reframed a lot of my questions. And I'm really determined to continue researching and continue trying to answer many of these questions, and keeping an open mind about long COVID.
Yeah, and I think that's absolutely terrific. I sort of said that would be the last word, but a couple of further questions have come in that have really sort of piqued my interest. So I'm going to ask you a couple more questions, if I may. A few people asking, what are the parallels between long COVID and chronic fatigue syndrome, or ME? And is there anything we can learn about treatments of those conditions that we could apply to long COVID? Or in the reverse, a bit like the sort of analogies between COVID and flu, can it sometimes be a little bit dangerous to try and relate one disease to something else? I'll go in reverse order, so give that one to you first, Betty.
Sure. So, I mean, so people who've had chronic fatigue syndrome say that when they look at or listen to others who've now been diagnosed with long COVID, that they're basically looking at someone exactly like them, so someone in the mirror. And the point they're trying to make here is that there are a lot of symptoms in common. But there have been some reports where there are some symptoms that seem to be more prevalent or more dominant among long COVID patients. One of them is brain fog. And so I suspect what's going to happen is that among patients who have long COVID, there will be a subset, fairly large subset, in whom there will be quite a bit of overlap with chronic fatigue or CFS, and they might end up having similar sort of treatment options. Now, what are the treatment options? I have to say, I'm not an expert in CFS, so I can't answer that question. But there are therapies out there that are being tested and trialed. Exercise is controversial, but that's where I'll stop for that answer.
Yeah, and I'll give the same from an immunology slant, Danny, to you. Is it a good idea to use analogies? It might be lupus or CFS or Epstein-Barr, or potentially misleading.
No, I think it's definitely helpful and useful. I get asked a lot about chronic fatigue syndrome, and my answer is always a bit unsatisfying. It's a kind of Rosetta Stone answer that I don't understand one, and I also don't understand the other. But I hope that by understanding a little bit of both, I can kind of maybe do some decoding.
Yeah. That's. Do we know anything about the immunology of CFS? Like Betty, I'm not an expert on this.
Not much, not enough, and not much.
Yeah. So it emphasizes yet again this key point about doing the research and doing it rapidly and at scale.